So we are live now, sir. We will just wait a few minutes. There are 7 people online. You will comfortably share the screen, sir, right now, or you will wait for introduction to finish.
Whatever you feel.
What I will do is I will just uh, play one opening screen. Okay.
I am seen properly?
Yes, sir. You are seen properly. Just wait. So there are 4-5 minutes left, sir, for 7 o'clock. My mobile is showing 6:56 to be precise.
Okay,
So we'll just wait 4 minutes, and after 4 minutes we will start.
okay, no
Still,
problem.
your friend Dr. Professor Mulazim has joined from Pakistan. Dr. Rajendra Lalani, who is a very well-known person in the Indian pathology circle, has also said good evening. Good evening, Dr. Lalani, sir. Very nice to see you. Dr. Poonam Shinde has already said okay. So we'll just wait 3-4 minutes. It's 6:58. We will just wait 2 or 3 minutes before starting.
Okay, okay.
Click on the link and check. Sit here only. So my mobile says it's exactly 7 o'clock. We'll just wait few seconds before starting. So I will do a brief introduction and then we'll begin. So I think we should start. So good evening, dear friends, and all the respected doctors, teachers, and dear friends who have joined this webinar. I am your host, Dr. Sachin Kale, and I welcome you all to webinars of the Paths, by the Paths, and for the Paths series. Today's topic is oral malignancies or oral tumors, to be very precise. As all of you know, oral malignancies are one of the most common malignancies that affect human beings, and tobacco related products are the main culprit. All of us are quite used to diagnosing at least one, if not more, oral malignancies in every cycle. But intraoral soft tissue tumors are entirely different ballgame, and they are not the easiest entities to diagnose. To do the justice to this complicated topic, we have with us today a very able person. He is a very well experienced clinical cytologist and oncopathologist, and his cases are always very well worked up and very well presented. And he sets a very good example of an investigative pathology detective, if I may say so. He is our own Feluda, since he comes from the same Bengal that Satyajit Ray's famous detective Feluda came from. As you already know, he is none other than our Dr. Asitava Mondal from Kolkata. He is an MD from prestigious PGI Chandigarh. He was president of Indian Academy of Cytology in the year 2006, and he has worked as a vice president of IPM in 2013. He is recipient of 19 gold medals and 10 silver medals. He has published more than 100 articles in various journals. He has delivered orations in various states of India and abroad. He has been invited as guest speaker in more than 150 national and international conferences. He was felicitated with Lifetime Achievement Awards from Jharkhand, Rajasthan, and Chhattisgarh chapters of IIPN. He is also on the editorial boards of various journals. So, ladies and gentlemen, it gives me great pleasure to welcome Dr. Asitava Mondal, and today he is going to talk on intraoral soft tissue tumors. With this, I think I hand over the screen or podium to Dr. Asitava. Dr. Sir, you please share your screen and start talking.
Good evening, everybody. On behalf of Dr. Sachin Kale and on behalf of the webinar, I personally invite all the delegates and all the participants in this webinar in the evening on Sunday. And you sit with a cup of tea and relax and enjoy the scenic beauty of slides.
Yes.
I will not show the scenic beauty of nature, but scenic beauty of slides, which we enjoy very much in conferences. But as these conferences are not being held, so we have moved to webinar. And Dr. Sachin Kale is a very close friend of mine. Not a close friend, I will tell you, almost a relative of mine, whom I know for a long time from the IIPM conference. He is very, very active in Patho India. You can see almost alternate days something is coming in Patho India written by him. So it is my extreme pleasure and my gratitude and my sincere thanks and gratefulness to Dr. Sachin Kale inviting me in this webinar. Now I will start my lecture. on this subject.
While Sir is sharing the screen, I would just like to say that Sir is the first person to grace our webinar series twice, and he has promised further lectures. He has promised lectures every month or every 45 days. So we are looking forward to hearing his words of wisdom in future coming days also. Yes, sir. Now I can see that you are started presenting. Your screen is yet to come on, but it will come, I guess. Wait.
Now you can see the slides.
Yes, sir.
A diagnostic approach to intraoral soft tissue tumors. It is the third teaching session. Two sessions have already been done. With the second session with Dr. Sachin Kali. These are the things that we can share, but not for publication. Why I am taking the topic on intraoral soft tissue tumors that I will elucidate slowly. Now, to separate passion from pathology is to separate a person's spirit from his body. Those who are present, I think they love the subject of pathology very much. And if the pathology is in their heart and soul, to separate it from this is just like a spirit separated from the body. So this is the picture.
Sir, just small interruption. Can you just click on the hide tab in the center lower part? There is something called hide. Can you see that, sir? There is a white strip with hide on the right. Something is written at the bottom of your screen. Hide. Meet. Stop sharing. Besides that, there is hide. No. Don't stop sharing. Just click on the hide. Yes, very good. Now continue, sir. I won't interrupt you now.
Okay. Thank you very much for guiding me. Thank you. It is a new subject. So this is the picture of sunset in Kochi, where we find Chinese nets. And this picture has been taken in 2015 when there was an AFCON conference in Kochi. And I was there luck to see the sunset in the Arabian Sea. Beautiful sunset and the reflection from the sky which is coming from the water and the Chinese nets. Now this I want to highlight because this topic has been highlighted in the part of this, not whole, because you know that the lectures are given in national or international conference for 30 to 40 minutes. So part of the lecture has been shared in an oration of otolaryngology and head and neck surgery. And I have been awarded with this medal and felicitation and the plaque by the president. So this is our president that time when he awarded me with this plaque and the medal and the certificate. My gratitude to him before starting the session because most of the cases that were sent by him for referral on the soft tissue surgery of Intraoral. Juan Rezair has told long ago that despite all advances in molecular biology and other disciplines, the diagnosis of solid tumors is based on overwhelming majority on the cases what we see under microscope. But that days have passed by when he has written this long ago, because as we see, as time is passing by, we have to depend on IHC and molecular techniques, not only on morphology. Morphology remains definitely the ground level substance or the main bricks or the structure on which a building is based. But on that structure, now IHC and molecular is slowly coming up to give a good building structure and a good substance, good building with concrete appearance. Now, soft tissue tumors represent a heterogeneous group of neoplasms. That is the problem, heterogeneous group of neoplasms exhibiting a spectrum of histomorphologies. What are the spectrum? Suppose we take the commonest tumor, embryonal rhabdomyosarcoma. If we come across embryonal rhabdomyosarcoma, which is typical of appearance, then we can give a diagnosis. But if we see the varieties of intraoral sarcoma like solid variant, spindle cell variant, or anaplastic variant, then then it becomes atypical type of intraoral sarcoma. Then it becomes little problem because this type we are not accustomed and we cannot distinguish it. With overlapping features, suppose we take the intraoral sarcoma and alveolar sarcoma solid variant. So there we cases create real problems, and for that, not only IC is not gives the clue because there are some overlapping IC patterns, one overlap with other intraoral and alveolar. If we don't find solid variant of alveolar, then we cannot distinguish with solid variant of intraoral with confidence. For which molecular studies are necessary. Molecular studies are necessary for alveolar abdominal sarcoma, where we find that there are some molecular special morphological molecular features that we found in cases of alveolar abdominal sarcoma, which usually carries a poor prognosis compared to embryonal abdominal sarcoma, where we find FOXO1 gene fusion with PAX3 or PAX7. So these molecular alterations are necessary to study distinguish between embryonal and alveolar abdominal sarcoma. The classification and diagnosis of soft tissue tumors have improved with the recent molecular techniques and IC. It is important to understand not only the diagnostic utility but also their potential limits and pitfalls. The clinical and radiological correlation are still a must to render accurate diagnostic, prognostic, and therapeutic information because as we have given the example of embryonal which carries a good prognosis as compared to alveolar abdominal sarcoma which carries a comparably poor prognosis compared to embryonal abdominal
Dr.
sarcoma.
Mondal sir, sorry to interrupt you. There is a lot of background noise. Are you using your same laptop or like different laptop? Last time it was very clear. This time there is a lot of background noise and audio is not clear. That is the general comments that people are giving.
I am using the same laptop.
Same laptop. Uh,
Uh,
is there some noise in the house or something?
no,
Or
I am using. I will open this here the earphone.
are you using earphones or laptop?
I am using earphone.
I think earphones won't be needed. Laptop would be sufficient, sir. Don't use earphones.
Now it is clear.
Sir, remove the earphone from the laptop.
I have removed it.
Unplug from the laptop also.
Yes, I have removed from the laptop also.
Yes, sir. Now you are better. Your voice is better now.
Now it is better.
Yes, sir. Yes. Now
Okay
continue.
then. Yes. Now soft tissue tumor and update. If we see the update, there are 12 groups according to histogenesis. Adipocytic, fibroblastic, myofibroblastic, fibrohistocytic, smooth muscle, pericytic, skeletal muscle, vascular, chondrosarcoma, gastrointestinal, stromal, nerve sheath, uncertain differentiation, and undifferentiated or unclassified. Tumor behavior can be divided into benign, intermediate, and malignant. Definite diagnosis of soft tissue tumor is to evaluate clinical radiologic, histological, and cytological features to generate histogenesis. Molecular and genetic testing is increasingly finding its application in soft tissue tumors. ISC plays an indispensable role in defining tumor histogenesis and also serves surrogate for underlying molecular and genetic alteration. This ISC now plays a major role. When ISC cannot give a diagnosis, then we have to take the help of moleculars. The ultimate goal, what is your ultimate goal? Not the ISC, not the molecular, not the morphology, but specific diagnosis because we want to treat the patient and to make the prognosis. Prognosis means whether the tumor will respond to therapy, whether there will be recurrence of the tumor, if recurrence, what severity of the recurrence, lymph node spread, vascular spread. So that is very important. And how much the tumor is removed, resectability and the removal of the tumor. That is very important. Now, classification of soft tissue tumors, if we classify, these are round cell, epithelioid cell, spindle cell, myxoid, adipocytic, and pleomorphic cell tumors. Now, soft tissue tumors of the oral cavity, we see that the soft tissue tumors majority occurs in the limbs, in the muscles, in the long bones, on the muscles on the long bones like that. Sometimes it occurs in the retroperitoneum. It occurs also in the head and neck region, but intraoral is really common. because these cells of sarcomas in the oral cavity are mesodermal in origin, difficult for correct diagnosis and proper therapy. 5 to 10% occur in the head and neck region and 1% in the oral cavity. 80 to 90% adults and 10 to 20% are children. Most common is rhabdomyosarcoma, known for repeated local recurrence and metastasis. Now, if we classify soft tissue sarcomas of the oral cavity, they are high-grade soft tissue tumors, of which they are malignant fibrous histiocytoma, malignant peripheral nerve sheath tumor, fibrous sarcoma, leiomyosarcoma, rhabdomyosarcoma, alveolar soft part. These various types, liposarcoma, angiosarcoma, synovial, myeloid, all occurs in the oral cavity according to the sites. And some majority of the tumors, of these soft tissue tumors, occurs also in the tongue, because tongue is a structure made up of muscles, blood vessels, nerves. So why not the tumor of the soft tissue may occur in the tongue? This is uncommon definitely, but it may occur in the tongue also, as there are muscles of the skeletal muscle like muscles in the tongue itself. So this may occur in the tongue also. Low grade are inflammatory myofibroblastic tumor and solitary fibrous tumor. Diagnosis is we can do cytology, because in carcinomas the main problem is there is an ulcerated lesion, it bleeds, and the mucosa is already denuded. The tumor comes outside. We can scan T cells, and this is the not problem with the soft tissue sarcomas, where we find it is an intact mucosa. It lies in the submucosal area. We can get lot of material from this aspirated material, and we make slides. We do not usually do many slides from cytology, 2 to 3 slides, and the rest we can do the cell block. The treatment is surgery, neoadjuvant chemotherapy, targeted therapy, and radiotherapy. First step and second step.
Just interruption, small interruption. Still, there is bit of background noise. Can you just check some paper is rustling there under the laptop, or some paper is rustling, or some tablecloth is rustling, or your audio, like it is full volume at your end?
Yes, the audio is full volume.
Okay. Okay, then continue. I guess that's the best we can do. Please continue. People were saying so, that's why I had to interrupt. I think I will not interrupt now.
What is the problem?
They are saying that there is some background noise.
Oh, background noise. 1 minute. Will I check?
I don't think there is house noise in the house. I think the room is closed. Everything is closed, I guess, right?
Now the sound has gone.
Yes, sir. Yes.
Now it is clear.
Yes. What was it, sir?
It was the AC was putting on.
Okay.
I have put down the AC.
Okay, sir. Now it's better.
I have put off.
Please continue.
Okay. Then the diagnosis of soft tissue tumors we have to do from cellular morphology. The cellular morphology, we have to put it that it is a mesenchymal in origin. And number one, that is most important, mesenchymal in origin. The cells may be round cells, spindle cells, pleomorphic cells, or mixed cell population. That is, we have to see what type of cells are there. Very important is in the background. Background material we should not neglect, and for this MGG stain is a perfect stain. PAP stain gives the nuclear detail, but the background detail is given by the megronal Giemsa stain. So background detail is very important in soft tissue tumors. The cells must be mesenchymal in origin, and for this we have to do IHC. Categorize the cell by morphology. Special stains are also play a good role in diagnosis of certain tumors. Now, if we do the round cell tumors, lymphoma, though it's a separate entity, but previously it was called a lymphosarcoma. So this is also sometimes included in some of the areas of round cell sarcomas. Lymphoma, Ewing sarcoma, these are CD45 LCA. Ewing sarcoma, you can do CD99 FIL1 molecular techniques also. Rhabdomyosarcoma, embryonal, alveolar, or pleomorphic, we can do desmin, myogenin, MIT1. Undifferentiated synovial sarcoma, that is a very much diagnostic problem with other round cell sarcomas like Ewing's or this, and for which we have to do CD99. But whatever you do, there may be some problem, and for which we have to do SYT-SX gene fusion transcript. That is the most important, and here comes the molecular role in undifferentiated round cell tumors, which are either synovial cell origin or other round cell like PNET or Ewing's or extraskeletal Ewing's, that creates problem. Small cell osteosarcoma, osteonectin, osteocalcin, and alkaline phosphatase, mesenchymal chondrosarcoma S100 and CD99. So spindle cell is leiomyosarcomas where it was SMA and muscle actin and desmin, fibrosarcoma, muscle actin, MPNST S100. These are the routine tests that we usually follow. MFH by exclusion, monophasic synovial sarcoma. This also creates problem with spindle cell carcinoma or spindle cell sarcomas. Monophasic synovial sarcoma with spindle cell carcinoma creates real problem. Then angiosarcoma spindle cell type creates problem. If it is a compact type of spindle cell angiosarcoma, then we have to take the help of CD31 and CD34. Of the two, CD31 is more specific. Kaposi sarcoma, yes, this is, we have to keep an eye how we can diagnose Kaposi sarcoma, because this is a spindle cell variant of angiosarcoma, and we have to see whether we have to do the HHV-LN1, that is a hepatitis virus 8 latent nuclear antigen 1, that is the marker for Kaposi sarcoma. Along with CD31 and CD34, it also comes positive with other angiosarcomas. Now I will go case by case. So what we find is a young child, and the child, we can see that this eye is opening, this eye is closed. He cannot open the eye, and there is some swelling in the face over this region. And this is the part where there is a bulge in the supraorbital bulge. Now, if we see the patient, there is a nasal bleeding from there. The eyes is closed and the supraorbital part is closed. And this, you cannot see, this is a bulge, supraorbital bulge. And this is the swelling in the face. We can see definitely there is a temporal region swelling, along with facial swelling. And this, on opening the mouth, we find a huge mass. Nasal bleeding, eyes paralyzed, swelling in the temporal region, and the swelling in the face, along with an oral swelling coming from the palate. So if we see the CT scan, this is from the anterior part where you find that the sinus is involved. The sinus involved, orbital medial wall is destroyed, the tumor has protruded in the orbit, and that is why the optic nerve is also involved in certain cuts. We can see not only that, the base of the skull is involved by the tumor. And if we see the posterior part, we find that this is from the palate the tumor has come up. Almost the whole oral cavity is occupied by the tumor, and it has gone up to the level of brain and destruction of the base of skull. So, and if we see the tumor by cytology, very good material may come out. The cells are rounded, isn't it? The cells have vacuolated cytoplasm, and some cells are binucleated. So what will be the diagnosis? Taking into the child and this morphology, and if we see the better morphology over here, but here we find very classical of intracellular vacuoles. The cells are rounded, some are binucleated cells, and there are binucleated cells. And so based on this, we can do a Desmin study, because commonest tumor of soft tissue is of rhabdomyosarcoma. So Desmin has come positive. See, this is from the cell, from the cytology material itself, and we can do the Desmin has come strongly positive. And the cell block is also comes out very nicely. You can see the cells over here. The cells have amount of cytoplasm, pinkish cytoplasm is there in the cells. Along with that, there are mitotic figures, good amount of mitotic figures. The cells are rounded and they have prominent nucleoli also. Now, if we do the immunohistochemistry, we can see that vimentin is positive, desmin positive, muscle actin positive, and myogenin is positive. And this negative is pan-CK, LCA, CD99, and chromogranin. This is embryonal rhabdomyosarcoma of palate with bone destruction and invasion to brain. Now, if we see this patient, see the patient is very, almost a small, not much aged. This is the tongue, this is the uvula, this is the tumor coming from the buccal part. Intact mucosa, that is important, intact mucosa. There is no ulceration. And this is the tumor. This is such a big tumor coming from the buccal muscles in the lateral part. This is such a huge tumor over here. Now, what are the cells? See the cytology. Cytology itself gives a diagnosis, isn't it? We find connective tissue strands, and the cells are attached to the connective tissue strands. Some are floating, so giving a pattern of alveolar pattern that we find in the lungs. So the cells have attached to the connective tissue. Some are floating and giving an alveolar pattern. The cells are rounded, similar to the cells that we find in embryonal rhabdomyosarcoma. But this cell, if it becomes compact pattern, then it becomes problem. So even in high power, we can see that these are the connective tissue strands, which are a spindle cells variety, and these are the rounded malignant cells. And if we see the cells and we find the cell block, we can find the connective tissue strands over here, and the Desmin is positive. So the cell block itself actually simulates similar to the cytological picture. This is alveolar rhabdomyosarcoma of facial muscles. Now, this part of this, now which is which tumor? There are two tumors. This is alveolar rhabdomyosarcoma and embryonal. Which one is which? Because of compact type, very difficult to distinguish between the two. One is of alveolar, another is of embryonal. And if we see, this is the solid variant of alveolar rhabdomyosarcoma. This is an embryonal rhabdomyosarcoma. We cannot distinguish by this, because this is a very difficult area where the solid variant of alveolar and embryonal. We have to go the treatment of embryonal and alveolar. They differ significantly, and so is important to establish a definite diagnosis for initiation of therapy. Embryonal rhabdomyosarcoma has a more favorable prognosis than alveolar. That is important. Alveolar rhabdomyosarcoma that I have already highlighted, that is a recurrent translocation, 80% cases with FOX1 and PAX3 gene, most common. But this fusion gene has a poor prognosis. So in these cases where we find solid variant, we have to take the help of molecular. Even the IHC pattern is not sufficient. And here comes the importance of the sophisticated diagnostic techniques in soft tissue tumors. Now this is the patient where you find, see the beautiful tumor over here. And this tumor is almost covering the palate and the adjoining area of the oral cavity. We find it is covered by intact mucosa, multilobulated tumor, and this is the tongue. But there is no ulceration. This is a very characteristic feature of soft tissue. There is no ulceration of the mucosa because it is a submucosal growth, not a mucosal growth, submucosal growth. Mucosa is stretched, but it grows inside, but usually it does not ulcerate. Now these are the spindle cells. We can find very closely packed spindle cells. The cells are oval, and the ends are rounded. We can see that the cells end are rounded. They are not elongated or pointed ends. They have abundant cytoplasm. There is nuclear pleomorphism over here. Some multinucleated cells are present. And if we go to the higher power, we can see these are the rounded ends of the cells. So that itself, if we spend time on cytology, we can give a diagnosis. And if we do the cell block, it further adds to this because the cells are rounded. There are pleomorphism, there are mitotic figures, and hymentin is positive, SMA positive, muscle-specific actin positive, EMA, cytokeratin, and S100. This is not a neural tumor or a epithelial malignancy or a synovial sarcoma, but it's this cell block. So the cytology, cell block, and IHC. On the cell block, SMA is positive. So we can shorten out our IHC pattern if we can give a good cytology and histological findings. Leiomyosarcoma of soft palate. So oral leiomyosarcoma, slowly enlarging submucosal form, non-ulcerated, well-circumscribed, painless mass adherent to surrounding tissues, 3 to 10% in head and neck area, less than 1% in oral cavity. Origin is from smooth muscle cells, pluripotent cells. IC is essential for diagnosis because it resembles other tumors like synovial sarcoma, monophasic. But the cell character of synovial sarcoma, they are short cells. The cells are smaller in size. They do not have much pleomorphism, so they do not have much mitotic figures as in leiomyosarcoma. But monophasic synovial sarcoma, name implies that a monophasic means it is a monotonous appearance, small cells without pleomorphism, without mitotic figures. Leiomyosarcoma should be treated by wide surgical excision. Another tumor, again, such a big tumor over here, multilobulated tumor from the oral cavity. So this is a multilobulated tumor. And these are the cells. What we find cells, these are the very thin wall blood vessels going there, and these are the cells that we see here. And if we go on to the other part of the very beautiful thin wall blood vessels going there, so branching capillaries like structure, and these are the very classical of lipoblast like cells, and these are multinucleated cells. So this gives a diagnosis of a definite tumor, and these are the pleomorphic areas. These are the very classical of lipoblast. So lipoblast, highly atypical cells, nuclear pleomorphism, prominent nucleoli, and along with this is a PAT stain where we find these are the fat cells and these are the lipoblast. So this gives almost to a confirmed diagnosis, and taking into the multilobulated nature. And if we palpate the area with our finger, we can see that the tumor is little bit of like just like liposarcoma. If we do grossing on this, the similar is the feature appearance as well as the filling of liposarcoma. This is multinucleated cells, and these are the fat cells, and this is the classical lipoblasts. So on histopathology, we can see very classical lipoblast, multi, and the mitotic figures. So this is diagnosis is almost no need for doing any IHC. It is a pleomorphic liposarcoma. Now another tumor coming from the oral cavity, it is protruding. See, this is the uvula, and this is the mass. Again, a multinodular on appearance, but is strictly adherent to. See, the tumor is growing without ulceration. It is adherent to it, but the mucosa is stretched. And this is the tumor. We can see this is the lateral wall. These are the mandibles. This is the base of brain, and this is the and the skull bones, the base, and these are the mandibles, and here is the tumor. So if we see the tumor, and these cells are quite different from the cells that we see in leiomyosarcomas, where we find that the cells are spindle-shaped, pointed ends, abundant cytoplasm. See that the tail ends are going there. There are abundant cytoplasm. Mitotic figures are present over there. And if we do the cell block, and this is a palisading arrangement, and these are the mitotic figures over here. Nuclear pleomorphism is over there. And IC, if we do, this is S100 is positive. So more and more the cells become differentiated, more and more S100 becomes positive, and more the cells become undifferentiated, then it becomes S100 becomes patchy in nature. The tumors are excised. Why the tumor is excised? That is very important. If we give a diagnosis on this, why the morphology, histopathology is necessary? Because to rule out heterologous element. If heterologous element like Triton tumor, rhabdomyoblastic differences, epithelioid cell mixture or lipoblastic, then prognosis will differ markedly from a not a homologous variant of a peripheral, malignant peripheral. That is why the tumor should be excised when you find malignant peripheral nerve sheath tumor, which is quite big in nature. And we find that these are the cells arranged in palisading pattern and very characteristic arrangement of the cells that gives a diagnosis. So these are the cells and these are the mitotic figures. Tumor giant cells are there, and these are the cells. So this is a very characteristics of malignant peripheral nerve sheath tumor. And we already have done S100 on the cell block itself, and which have shown positive. So malignant peripheral nerve sheath tumor. Another tumor, you can see that a huge multilobulated tumor. So clinical photograph is very important, and it is my hobby to take clinical photographs of the patient before performing any FNAC. And this is the multilobulated nature of the tumor. We can see over here, there are multiple nodules coming from the surface of the tumor itself. So this is the tumor coming up, and this is the tongue is pressed, and this is the huge tumor. It has to be excised. So, and on FNAC we can find that there are pleomorphic, and these are the multinucleated giant cells, these are the large cells, these are the small cells, which is a highly pleomorphic tumor. And on other high power, we can see this is a large nucleolus, huge size nucleolus, and these are the bizarre mitotic figures. So this is a highly pleomorphic malignant tumor, and on cell block we can find very characteristic storiform pattern or cartwheel pattern. So this pattern, we have the idea that if we make cell block from aspirated material, the pattern is lost. No, the pattern is not lost. We should not crush the material. Once we crush it, then the pattern is lost. As we do in endoscopic biopsy, this tissue remains. The fragments of tissue that we have to process very carefully so that it remains the morphology. The morphology remains intact in case of cell block, where we find very classical of cartwheel pattern. So this is a storiform pattern of growth, and we can find this is also another area where we find the storiform pattern of growth. And we find multinucleated giant cells, highly pleomorphic cells, and these are the mitotic figures are there, plenty of mitotic figures. And if we do the IHC pattern, because we have to exclude certain tumors, vimentin is positive, CK is negative, desmin is negative, HMB45 is negative, CD34 is positive only in the blood vessels, SMA focal positive, S100 focal positive, very focal positive, CD68 is positive in the giant cells, proliferative index is 40%. So it is a pleomorphic sarcoma. Now, pleomorphic sarcoma is high-grade sarcoma, aggressive, occurs in 50 to 70 years of age. Less than 3% occur in the head and neck region. 5 histologic types, storiform and pleomorphic, giant cell type, inflammatory, angiomatoid, and myxoid. Cell of origin is primitive mesenchymal cell, fibroblast, and histiocyte derived from active progenitor cell. And this is another tumor coming from the palate. This is the hard palate. This is soft palate. The tumor is coming from the soft palate. Hard palate is intact. This is the margin between hard palate and soft palate. And these are the rounded cells, prominent nucleoli, right? Good. They have cytoplasm. Good amount of cytoplasm is there in the cells. And we did a cell block. Cell block also showed similar type of monomorphic cells. See the well-dispersed cells as in cytology. And there are some mitotic figures. Over here, we can see that the cells have chromatin pattern, but it is a malignant. There are plenty of mitotic figures we can see over here. And we did a multiple IC pattern, all were negative, except the CD99 was positive. So what is this tumor? That created a lot of problem in us. And we thought it possibly of an Ewing sarcoma, malignant round cell tumor of soft palate, possibly Ewing sarcoma. But when the tumor was excised, we can find a whitish area along with the bluish part. This bluish part is made up of small cells. And the whitish area, if we go under high power, we can find these are the cartilaginous area. And the cartilages and the cells are in the lacunae. And the bluish part is the small, rounded, undifferentiated cells. And this is the hemangiopericytoma like blood vessels over here. And these are the cells of rounded cells. So what are these tumors? White clouds in a blue sky, bimorphic histological appearance formed by islands of white mature cartilage with a background of densely packed blue primitive appearing cells and hemangiopericytoma-like areas. So these white clouds are there in the blue, that is the cartilaginous area, mature, and the cells in lacunae, and the blue are the undifferentiated rounded mesenchymal cells, and this is S100 is positive in the cartilaginous area, CD99 was positive in the round cells area, mesenchymal chondrosarcoma of soft palate. So this is a really and very interesting case, and we are foxed by the diagnosis because only the round cells have come up on cytology. Now this tumor created a huge problem. But the tumor looks a highly vascular tumor, isn't it? It has the alveolar is pushed, and this is the tumor. There are plenty of pinkish blood vessels. Some are bluish areas. These are the bluish areas. These are the pinkish area. Means these are the areas of hemorrhage which are undergo organization. These are the fresh areas of blood vessel. New blood vessels are formed. These are the areas where bleeding has occurred and it has organized. So if we see on the closely, we can see that these are the areas where we find that there are some reddish area. That is the areas of pinkish, and these are the bluish areas. So, and if we see the cytology, we can find these are the spindle cells. Spindle cells arranged in pattern over here, and we can see they are beautiful spindle cells. And the spindle cells are almost little bit pleomorphism, but there is no mitotic figure. So this is a spindle cell tumor, no doubt about it. But on histology, we find these are the spindle cells, but these spindle cells are separated by gaps which are filled by RBC, isn't it? These are the cells filled by RBC. These are malignant spindle cells. There is no doubt about it. And these are the mitotic figures. The spindle cells are arranged in pleomorphism is there. And these are the RBC. And this is a diagnostic of promontory sign. What is promontory sign? Growth of a blood vessel within a vessel. So that is we have to search for it. This promontory sign is very important for diagnosis, along with the spindle cells with the spaces in the gaps which are filled with RBC. And these we see that these are the spindle cells, right? And these are the RBC in between the gaps. So these are the important areas: spindle cells, pleomorphic, and the RBC. So can we diagnose at this stage without doing any IHC pattern? Yes, we can have an idea because of the nature of the tumor, because that is the important of clinical examination of the patient, because that gives an idea that there are areas of highly vascular nature.
Just if you want to ask audience for diagnosis, you can just wait 30 seconds. You can just say, I wait for the diagnosis. When the audience gives the diagnosis, I will read it out. If you want to do it like that.
Okay, okay. This is a very interesting case, challenging case for us.
So, audience, can you write the diagnosis in the chat box? Any diagnosis at this stage? There were RBCs, there were spindle cells. Audience, can you hear us? Rathi S has said Kaposi sarcoma.
Ah, good, good. From where is he?
Rathi, Dr. Rathi, where are you from? Ritesh Kumar Gujar has also said Kaposi sarcoma. Dr. Deepak Kanapur has said angiosarcoma.
Yes, it is a angiosarcoma, but the classical appearance of the spindle cells and the RBC in between the grooves, in between the spaces of spindle cells, that is very characteristic.
Yes, sir. Yes, sir.
And another characteristic feature is a promontory sign. This promontory sign, this is very important. Vessel, this is a blood vessel, and inside the blood vessel, another blood vessel is growing.
Yes.
That is a promontory sign. That is a very characteristic feature. But those who are doing the diagnosis of Kaposi, I really am very thankful to them. Not only thankful, they are listening to it so nicely that gave a diagnosis on this. This
is very. Wait for the diagnosis after every case. Means before revealing the final diagnosis, you can wait. Whatever the details that are in there.
Then I will wait. That is better way. Okay, okay.
Yes.
And this is an angiosarcoma. There is no doubt about it. But this is the promontory sign we can see here. This is the blood vessel and another vessel growing from it. So the IHC pattern is so characteristic in this case, and these are the prominent. This is a very CD31 is better stain than CD34. So it gives a diagnosis of angiosarcoma. There is no doubt about it. It's CD31 positive, CD34 positive. But this promontory signs, growth of spindle cells, groove-like spaces in between the spindle cells, inspissated RBC, and one characteristic that I have not shown, it is not coming in the picture properly, is the intracellular hyaline globules, which are PS positive, which are inspissated RBC. That is one of the characteristics of a Kaposi sarcoma. So all the signs are there of Kaposi sarcoma. Only we have to do the stain of HHV8 LNA, latent nuclear antigen hepatitis B, virus 8 latency nuclear antigen test. That is a nuclear stain. It has come very strongly positive. So intraoral Kaposi sarcoma, I think this is one of the rarest tumor. It gave a lot of problems. So that gives a clue. Previously, I used to see the patient without wearing gloves. As you have seen already one that a tongue tumor, I will show you that I have taken the photo with my finger over there. But once we came across this Kaposi sarcoma, we become very cautious that we should not wear proper gloves. But if we wear gloves, now the picture, the interesting part of the picture goes away, because these gloves and all these things becomes very cumbersome. So I cannot stop my temptation.
So it was not known that patient is immunocompromised, is it?
Yes, it was positive for.
And before, like FNAC, it was not known, or like?
Not known. Problem, 30 days I have to abstain myself.
Okay, great.
My test was done.
Okay.
So HIV infection, HIV was positive in this case. So that, but luckily I did not prick my finger.
Great. Otherwise you would have to take.
It was and from there onwards I wear gloves, but I become hesitant. Photos do not come well with wearing gloves and all. So pathogenesis of Kaposi, if we can see, it is a low intermediate grade vascular malignancy caused by Kaposi's sarcoma herpes virus or herpes virus 8 infection. Spindle cells may be from which type? Lymphatic endothelial cells due to HHV8 infection, vascular endothelial cells, or endothelial progenitor cell. How it occurs? because it is an oncogenic tumor. Oncogenesis, because viral oncogenesis causes endothelial cells infected with HIV-8 undergo altered lymphatic differentiation and manufacture cytokines, creating a favorable milieu for angiogenesis. So this causes angiogenesis. HHV8 encoded latency associated nuclear antigen is an immunodominant oncoprotein which promotes cellular transformation and viral oncogenesis. Lymphatic associated genes are upregulated in endothelial cells, including lymphatic vessel endothelial receptor 1, then podoplanin vascular endothelial growth factor receptor 3. However, HHV seropositivity is much higher compared with Kaposi sarcomas. So that is one should keep in remember that HHV seropositivity is much higher than is Kaposi sarcoma. Other cofactors also play a role like host immune dysfunction, local inflammatory milieu. HIV infection augments HHV replication. So if the patient is HHV positive and there is associated HIV infection, that then increases the severity of the disease increases. So now the soft tissue tumors of tongue. How can we raise a suspicion that the patient has soft tissue tumor? That is why very important to have to see the patient, because clinicians who do the biopsy, usually they take the biopsy and sometimes it becomes a failure because they usually the mucosa comes, they do not go into the deeper part of the tumor. So for which we have to put the needle and we can get the material and gives a diagnosis that's not an epithelial but a sarcoma. So see this is the tumor. We can see here that there is a large tumor bulging here. The papillae is almost stretched, and the tongue, what is the tongue? Tongue is deviated. This tongue is deviated. That clinches a diagnosis, possibly a soft tissue of neural origin, because this is the tumor which has deviation, hypoglossal nerve is involved. And this is the normal tongue, and this is the normal part, and this is the not deviated to the midline. Midline is there of the tongue, and this is the stretched part of it. It is growing on the dorsum of the tongue, and it's quite big tumor. And FNS you can find spindle cell pointed ends. That gives a clear-cut indication that it's a neural tumor. And we can do the cell block, which is also a spindle cell tumor, and S100. See, this S100 positivity is much stronger than the S100 positivity that we have seen in malignant peripheral nerve sheath tumor. So if the neural tumor is benign, S100 becomes strongly positive. If it becomes undifferentiated, S100 becomes more and more weaker. So neurofibroma. But compared to this part of the tongue is straight, isn't it? It is not at all deviated, but a huge tumor. It is much bigger than the neural tumor. But what is this tumor? The patient was asymptomatic except that when it grows very big, then it causes difficulty in deglutition and comes. But in case of carcinoma tongue, usually there is tremendous pain because of ulceration. Patient cannot take food. There occurs local bleeding and they cannot wash the mouth properly. There is also some offensive odor comes from the mouth. But here nothing occurs. And if we do the cytology, what we find, these are the glands. Glandular epithelial cells, right? These are some vacuolated cytoplasm, and these are the nuclei. So we find that's benign, monomorphic, no pleomorphism is there. And if we do the histology, we found that this is the stratified squamous pseudoepitheliomatous hyperplasia. These are the muscles of tongue, and in between the muscles, salivary structures, salivary glands. Well formed salivary glands. You can see these are the salivary glands, these are the muscles intermingled, and predominant salivary glands over here. And these are the muscles, and these are the clumps of salivary glands. So when you went to the literature, we can see that this is nothing but adenomatoid hyperplasia of the minor salivary glands of tongue.
Yes.
So
Sir, sir, wait for the audience to reply when you finish the case before revealing the diagnosis. Dr. Sharma has already replied as adenoma. And I think he's close enough. Adenomatoid hyperplasia of minor salivary gland is close enough. Dr. Sharma seems to have marked it.
Yes, sir. I forgot. Next time I will stop down.
Yes, yes, sir.
And this is the tumor that I was telling you that, see, this is my finger over there, and this is the undersurface of tongue. We find that the mucosa is stretched, isn't it? The mucosa is very much stretched, but there is no ulceration. We can see this is the close-up of the view, and this is the mucosa is stretched, and this is the tumor. Now on cytology, who will give the diagnosis? On cytology, we can give a diagnosis on cytology. What is the diagnosis?
Audience, you want to give diagnosis on cytology alone? That tongue tumor? No answers as of now because there is a slight lag, sir, between what we see. There is a
But
10-second lag, and they have not
but
answered. Maybe you can go ahead.
but yield is very good now, Dr.
Yes,
Sachin.
yes.
Yield
Yield is
is
very
very
good.
good. Yield is good. The cells morphology is good. And what are
Yes.
cells? What are these areas? What are these areas? Acellular areas.
Audiences, you want to say something?
Acellular areas, spindle cells. What is the arrangement? Is it palisading arrangement? Is it in compact pattern? What type of arrangement? So we have already told we have to see the cells. We have to see that the cells are usually a mesenchymal. As I am dealing with the sarcomas, all are mesenchymal, there is no doubt. And what are this arrangement? Arrangement is very important because on cytology, arrangement is comes up because we have don't crush it, we just spread it just like butter. And the cells. This what is the arrangement of these cells?
Sir, I think you will have to reveal. We are waiting for
Okay.
it.
You see, and on histology, we can find this one. Histology, can we tell what are these? These are the blood vessels, right? What are these? Acellular collagenous material. What are these spindle cells? Similarly, we can see this is a acellular collagenous material, right? That was there in cytology, that was there in histology also. Spindle cells, yes, these are the monomorphic spindle cells, no pleomorphism.
Dr. Archana Deshpande has said schwannoma.
Schwannoma.
Yes.
But acellular arrangement and there is haphazardly
Probably
arrangement.
Antony A and Antony B areas where something that must have been in her mind.
This is a haphazardly arrangement cells. It is not palisading arrangement.
Okay.
That is most important.
Myoepithelial cells, Dr. Gujar is saying. Are those
No,
myoepithelial cells?
see, these are the cells. Acellular collagenous material, patternless pattern of growth. This is
Dr.
patternless
Chetna is
pattern.
saying SFT. I think solitary fibrous tumor is what
Yes,
she was saying.
that word I have not used. Patternless pattern is the classical word.
Patternless pattern. Okay.
This is no pattern, absolutely no pattern. Here we find hemangiopericytoma like blood vessels. See the staghorn type of blood vessels, acellular collagenous material. And these are the cells, these are the blood vessels, acellular collagenous material, spindle cells, patternless pattern of growth. See, these are the areas.
Yes, sir.
There is no pattern. There are blood vessels, there are acellular collagenous, small spindle cells, no pleomorphism. See, these are the areas, acellular collagenous, patternless pattern of growth. And we can see there CD34, this is the marker. BCL2 is another, but this is a very characteristic. The cytology itself was thinking that whether this may be the result of this cellular arrangement. So CD34 positive, BCL2 positive, hymentin positive, CD99 positive, STAT6 is protein produced. This is a very important marker for soft solitary fibrous tumor. S100 negative, SMA negative, and desmin negative, cytokeratin negative, EMA negative. So epithelial, muscle, neural marker out. STAT6 protein is not done. We did a CD34 and BCL2 and vimentin CD99. What is the importance of STAT6? STAT6 protein is the thing which causes proliferation. Intrachromosomal fusion involving NAB2 and STAT6 genes in 12q13 locus. STAT6 converts NAB2 into transcriptional activator EGFR. That is important, which causes mitogenesis. So STAT6 proteins is the factor which causes mitogenesis and the cell proliferation, as we find in case of HHV8 LNA, which causes the oncogenesis of this the tumor that we have seen in cases of previous tumor that we have seen in such as sarcomas of the vascular nature, and this is the tumor that we have seen in case of solitary fibrous tumor. So solitary fiber.
So two
Now
people
this
have got it right. Sir, two people got it right. Dr. Chetna and Dr. Rana.
good,
And
good,
and one more
good.
diagnosis offered was neurolemoma. But I think
That
immunohistochemistry.
is there, but patternless pattern was very important. No, that and the blood vessels arrangement, acellular collagenous tissue. That gives a diagnosis. And this, if we see thoroughly on this and spend some time, then we can choose specific markers. If we do similar markers, hundreds of markers, become very costly.
Okay.
So that is the importance.
Yes.
This is a polypoidal mass. See, again intact mucosa, polypoidal mass. This is a polypoidal. See, this is the close-up view. These are the spindle cells. Abundant cytoplasm. See, these are the spindle cells, abundant cytoplasm. There is pleomorphism. Cytologically, we can tell up to spindle cell tumor, but not more than that. But on histology is very characteristic. These are the inflammatory cells, plasma cells, lymphocytes, and the cellular tissue, which is not much cells. If we go in the high power, we can see these are the lymphocytes and plasma cells, and these are the spindle separated cells that we have seen. So these are the areas where lots of inflammatory lymphocytes, plasma cells, and spindle cells. These cells have prominent nucleoli. There are some scattered mitotic figures. We can see these are the areas prominent mild nuclear pleomorphism over here. So what is this cells? Inflammatory cells along with the spindle cells.
Inflammatory myofibroblastic tumor is the first answer given by Dr. Ritesh Gujar.
Good, good.
Congratulations, Ritesh.
Thank you. This is the interesting part of a speaker with the audience. Now we cannot see the audience. It's missing so much. That is the important. When you over the dais and we can see that they are participating, it becomes so encouraging.
Yes, sir. Yes. That's why I'm trying to be the bridge between you and the audience, sir.
Yes, you are helping me a lot by giving that.
Dr. Ritesh has further commented the tissue culture appearance. Dr. Poonam Shinde has also said inflammatory myofibroblastic tumor. Nilesh has also given the same diagnosis.
So we cannot see the face. You can see. I cannot see. This is my drawback.
What we will do, sir, next time we will try to include most people in the this webinar itself, so that. But there can be some disturbance, but we will try. Sir. Okay,
but still to see the face and to see the eyes and face expression is very important.
Yes, sir. Yes.
For a speaker, at least for a speaker.
Yes.
And see, this is the spindle cells, and this still the inflammatory cells are there. Yes. And purpose of conference is going to meet people. That is most important instead of lectures.
Yes, sir.
Lectures from 10% to 20%, but others is the just meeting the friends and over here. We can see these are the spindle cells, right? And we can see there are mitotic figures. So this is definitely an aggressive variant, not an inflammatory myofibroblastic as a whole benign or borderline malignancy. This is definitely some areas where we find that the cells nuclear, then there are mitotic figures, prominent nucleoli, and nuclear pleomorphism is there. So more sections should be studied in this case, and ultimately we came to the conclusion that it is a malignant tumor. It was excised but not completely excised. The patient was followed up. There was repeated recurrences, but the tumor has invaded the deeper structures and ultimately multiple metastases occurred in the regional nodes. That is the follow-up of this patient. The ALK1 was positive, Vimentin was positive, SMA was positive, cytokeratin, EMA, S100, and desmin were negative. Inflammatory myofibroblastic. Congratulations and thanks to have given the diagnosis of inflammatory myofibroblastic. Thank you so much.
Yes, sir.
The term was proposed in 1990. We should remember that it is not a reactive healing process or immunological response of myofibrous to tissue injury. Inflammatory cells usually tells that whether we are going to basically a healing process or a reactive process, but no, this is a part of the tumor. It is a soft tissue tumor of intermediate or low grade malignant potential, but this tumor was of high grade, and we have seen that the patient has recurred several times. Ultimately, metastasis has occurred and the patient died of metastasis. It recurs locally invasive and rarely metastasized. That we have to give importance. So multiple sections of the tumor should be done to see the nature of this malignant nature. Ideal treatment is surgical excision and follow-up. Presence of chromosomal aberration indicates that it is neoplastic. Cytogenic abnormalities in 30 to 40% cases in the region of ALK1 gene. EB virus has been detected in situ hybridized in 60% cases. Now, this tumor, if someone tells from the clinical part, I will be very happy. What is this tumor? Clinics is very important. To see the photograph, that is very important. What are the red arrows? The red arrows I have seen. That is why I have taken the red arrows. What are the red arrows? Yellow arrow or white arrow is very important. This is the tumor. See, it has bulged out. This is nothing new.
Dr. Ritesh is venturing a case of schwannoma.
What are these structure? It is not a nerve trunk which has divided. Hypoglossal nerve should go this way. Hypoglossal nerve does not go this way. Hypoglossal nerve usually go this way. These are the hypoglossal nerve tract.
Dr.
But if
Sharma
you
is saying it is an indentation. Dr. Ritesh was thinking it's a nerve, so he was thinking of schwannoma.
see,
Dr. Janu is saying inflammatory myofibroblastic tumor again.
see, this is the blood vessel, and it has divided into two. I tried to put as much stretch on the tongue as possible because I can see with my eyes, which cannot so much come with the photos. These were the prominent vessel that was coming from the mucosa. And this is it has branched into two. We can see this is the vessel. This vessel has gone inside the tumor. This is also another branch. This is the main trunk. So if we go, these are the cells. Vacuolated cells, rounded cells, eccentric nuclei, good amount of cytoplasm. Nuclear polymerization is mild to moderate.
Any guesses, audience?
These soft tissue sarcomas are rare, but we have to take into consideration it occurs.
Okay, sir, you go ahead, sir.
Rod-like crystalloids are seen. Now,
Anyone wants to guess?
PhD positive rod-shaped crystalloids. What are these rod-shaped crystalloids? It is MCT1 CD147 transmembrane complex monocarboxylate transporter protein and its cellular chaperone. If this is present in the tumor, it will give for indication for target therapy.
Dr. Vaidya is saying hemangioendothelioma, and Dr. Chetna is saying ASPS.
Yes. Who has told ASPS?
Dr. Chetna.
Ah.
Dr. Chetna from, I think, Stanley Medical College.
Oh, yes, from Stanley Medical College have come. I have gone there twice or thrice. Possibly, this is a very good college, very old college in Chennai, Stanley Medical College. This photo is there. Very good statue of Stanley is there, who have founded this college. Very old college. But there are very warm reception over there. I had a lot of warmth over there when we went to Chennai. Twice we went to Stanley Medical College.
Great.
Very good.
And there are some other diagnoses also. Dr. Vishram Kulkarni is saying hemangioendothelioma. Dr. Chirag Parmar and Dr. Manoj Kahar are saying alveolar sarcoma. Dr.
Yes,
Ganesh Kumar is just saying sarcoma. Dr. Rakesh Vaidya again wants to say hemangioendothelioma.
Oh, Manoj Kahar is very good. I know him very well. He is a very good academician plus a very good practitioner. He has lots of collection. And I love him like my brother. He always encouraged me to do webinar, and he guided me also to give lots of books he has sent on head and neck tumor.
Yes.
Lots of books. So this is the histology. We can see this is not connective tissue strands. We can see the blood vessels. Right? These are the blood vessels. We can see RBC inside this. These are the very tiny thin wall. If we see it very fast, then we can make out connective tissue strands. But if we see thoroughly, these are the blood vessels. The cells are these. These are abundant pinkish cytoplasm. Abundant pinkish cytoplasm. So these cells, some people think that is a rhabdomyoblastic differentiation, or the cells are from rhabdomyoblast. But truly speaking, is it rhabdomyoblast or uncertain histogenesis? Till now, they are telling it is uncertain histogenesis. But some, looking at the cell, they are thinking that is a rhabdomyoblastic differentiation. So these are the blood vessels. See, very tiny, thin wall blood vessels. And the cells are not much pleomorphic. They have abundant cytoplasm, pinkish eccentric nuclei, prominent nucleoli. But the tumor gives rise to rapid metastasis. Very extensive metastasis occurs, particularly to lungs and brain. This is an alveolar soft part sarcoma. So this is PS. I have already given you the clue that PS positive diastase is a needle-like structure, which is very characteristic of alveolar soft part sarcoma. MYD1 cytoplasmic only TFE3 was positive, alveolar soft part sarcoma. Now this is another tumor. See that we can see varieties of tumor in the tongue. The tongue is almost fixed. We can see that there is no papillae. It is stretched by the huge tumor, bulging tumor. These are the cells. What are these cells? Can we see? There are spindle cells, no doubt. But what are the nature of the spindle cells? Are they elongated? Are they club-shaped? And see the nature of these spindle cells. What are the type of these spindle cells? They are not pleomorphic. There is no mitotic figure. There is not much necrosis, right? If we go on the high power, these are the cells, spindle to oval shaped cells, hardly any nuclear pleomorphism, mitotic figures. Spindle cell, is it benign? That creates problem. But if we see clinically, it doesn't look benign, isn't it? The tongue is so much stretched, fixed tongue. Tongue is fixed to the base. It is absolutely fixed tongue. And histopathology, if we can see, these are the spindle cells arranged compactly, compact pattern. See, these are the cells, spindle cells, small spindle cells. So small spindle cells, then there is not much pleomorphism, no mitotic figures, hardly any mitotic figures, no necrosis. What type of tumor it will be there in the tongue of a spindle cell nature?
Audience, you want to have a go at this? Any comments, audience?
We did a panels of because it was
Dr. Deshavara is saying fibrosarcoma.
We did a panel of ISC in this case because it was we are very much focused, but the cells characteristics is we are looking for small spindle cells, not pleomorphism, not mitotic figures, no necrosis. Cytokeratin was positive, BCL2 positive, hymentin positive, EMA positive, TLE was
Sir, synovial sarcoma diagnosis has been given by two people, Dr. Ritesh and Dr. Manoj Kahar.
Yes, Manoj is very good.
Ashok Prasad is saying fibrosarcoma, undefined malignant potential.
It will come up definitely. It will all spindle cell tumors will come up. That is why we did a multiple of IC pattern.
Dr. Benito is also given synovial sarcoma.
Yes. TLE is a marker for synovial sarcoma, no doubt, but it is overlap. There are neural tumors also give TLE positive. So cytokeratin, BCL2, EMA is a very good marker of synovial sarcoma. EMA is positive, TLE positive, BCL2, cytokeratin and hymentin both are positive. And these cytokeratin, hymentin positive in a tumor, spindle cell carcinoma creates problem, which are also positive for cytokeratin and hymentin. So these cases are real creates problem of spindle cell carcinomas. So CD34 was negative, Basmin negative, myogenin negative, SMA negative, MIT. So muscle markers, solitary fibrous tumors, and all these are come negative. Monophasic synovial sarcoma. These are the areas of variants of synovial sarcoma. What are the variants? We can find bone formation. There are one or two soft tissue tumors where we find bone formation which can be detected radiologically. One is synovial sarcoma, another is malignant fibrous histosarcoma. So this bone formation is one of the characteristics of synovial. If we see a soft tissue sarcoma with bone formation and the spindle cell nature, we can possibly label as this. Then there is thick collagen, keloid-like collagen. That is important. Keloid-like collagenous pattern that is present in synovial. This is keloid-like collagenous. And hemangiopericytoma-like blood vessels. This is called staghorn blood vessels. So these three are the characteristics of some of the characteristics of the variants of synovial sarcoma. So we must keep in mind if we find staghorn blood vessels, spindle cells, bone formation, then keloid-like collagenous tissue as cellular, we can think of it. But these are the problematic area is monophasic synovial sarcoma from spindle cell carcinoma, biphasic synovial sarcoma from sarcomatoid carcinoma, poorly differentiated synovial sarcoma from Ewing's. So these are the areas totally different diagnosis, totally different treatment, totally different prognosis. What we do in these cases? Will any of the audience tell what will you do if you see these cases of overlapping IHC, overlapping morphology, then what will you do?
Audience,
We
you want to
see,
say something?
we see in synovial sarcoma, this is cytokeratin BCL2 EMA is positive. CD31, these all are negative. But if we find monophasic synovial sarcomas from spindle cell, which are also positive for cytokeratin and vimentin, Sarcomatoid carcinoma, both are positive. Ewing sarcoma CD99 is positive. And, and this is very difficult to diagnose for synovial sarcoma from this. Even synovial, that is your spindle cell carcinoma with solitary fibrous, which is aggressive solitary fibrous tumor with local recurrence metastasis, and sometimes it creates problem because they are also, so these are the areas where there is lots of confusion between spindle cell, the sarcomas and epithelial tumors. These are the borderlines where you do EMA may be positive, hymentin both are positive in spindle cell carcinoma, sarcomatoid area. So what will you do in this case? We have to do the molecular. We cannot go with the SYTSX transcript. Either by RT-PCR or by yeast or fish, we have to move to this because we have to treat the patient. And for treatment, morphology is not sufficient. IC may be overlapping. And there are two types, biphasic and monophasic. Biphasic is SYTSX1 fusion. Monophasic is SYTSX2 fusion. And monophasic has better prognosis than biphasic. So we have to move to this cytogenetics and molecular. That is important for us because origin from undifferentiated or pluripotent mesenchymal, very rare in tongue, cytogenetics detection of translocation, analysis of this is diagnostic, SS is very aggressive and metastasized. Though the morphology does not correlate, but it's very recurrence and metastasis occur. Treatment is complete excision. Post-operative monophasic has better prognosis than biphasic. The only thing is that any spindle cell tumor with SYTSX transcript, we can label it as a synovial sarcoma. This is the only part. The SYTSX gene fusion in spindle cell sarcoma using RT-PCR, FISH or IS is synonymous with synovial sarcoma. Now this is the tumor. Tumor itself tells the diagnosis, bluish. Once we find bluish, what will you see? What will you do then? If we find a bluish tumor, what will you do? How it helps us? See whether the tumor is compressible or not. That is important. If we find a bluish tumor, we see the possibility of vascular origin. We can see whether it's a compressible tumor or not. So if it is a compressible tumor, soft tumor with bluish nature, we can think of a blood vascular tumor. That is one clue. So that is why the clinical photographs are taken. See, this is the huge bluish area in the tumor. And we can see the pulsatile nature of the tumor and very characteristics of the morphology. You can see the spindle cells, that is the connective tissue strands, and the malignant cells, that is the endothelial cell proliferation. So this is a very characteristic feature. But we have to take into guard doing the FNAC from the proper area. If we rupture a blood vessel, it will not come. So that is the importance of doing the imaging studies in this tongue. I could not get the images because this is a long time published article long ago, and this was presented in the conference over there. So exactly the imaging I cannot get in my collection over there, but we have to puncture the solid area, and we can get this type of cells. You can see this is the connective tissue strands and pleomorphic cells arranged around it. So this is the connective tissue. What is this tumor? I think majority will give a diagnosis.
Audience, you want to say something? Dr. Asaduddin Azad has said vascular lesion. Dr. Smita Zaveri is saying CD99. Dr. Neelam Sriman is saying translocation 1122. EWS.
But what we find over here? Connective tissue, that is the blood vessel.
Looks like a capillary.
Yes, exactly. This is a capillary-like structure, and the cells proliferate, endothelial cells proliferating over here. So if we see a blood vessel, there are some connective tissue strands on which the endothelial cells proliferate. So this is a very classical
now
appearance.
Diagnoses are coming, sir. Hemangioendothelioma. Dr. Yes. Ashok Prasad has said hemangioendothelioma.
Yes, it is a vascular tumor because the clinical part, we usually miss the clinical part. This is the bluish area, pulsatile area, compressible area. That gives a various causes that if we put the needle, only blood may come. Take the help of imaging, take the solid area. This is the solid area. This area is a totally blood will come. If we puncture this area, then we can get the solid material. So this is a tumor over here. We can find that this is CD34 positive, CD31 positive. And this is angiosarcoma. Now this is another,
okay, sir.
yes,
Go ahead.
this is another tumor. Huge mass. What are these cells? Multinucleated cells. Mitotic fibers.
Pleomorphism is there.
Yes, pleomorphism is there. But what very characteristic cell of this one?
Dr. Smita Javeri is saying mucocele.
What's he saying?
Mucocele.
Mucocele, but why this type of nuclear pleomorphism, then multinucleated tumors, giant cells, mitotic figures?
Maybe she's commenting about the previous case where that bluish swelling was there.
Now, bluish means the blood vessel. The bluish tumor is always the vascular nature.
Okay.
And what are these cells? These are
Dr. Ritesh is saying pleomorphic sarcoma.
It is definitely, but we see these cells. This is very characteristics of tadpole cells. Where do we find tadpole cells? Multinucleated cells, tadpole cells. Where do we find these tadpole cells?
Yes, I think we are waiting for the audience. Rhabdomyosarcoma, Dr. Asaduddin Asaduzman Asad.
He's from Dhaka.
Yes, he said so, sir. Chirag Parmar is saying RMS.
Yes, these are strap cells, absolutely. These are strap cells.
Go ahead, sir.
And see the cell block. These are the strap cells or tadpole cells. Pleomorphism is there. Mitotic figures are present. What stain will you do in this case? You see the very beautiful cell block. This is very tadpole cells. Multinucleated cells, pleomorphism is there, mitotic figures. This special stain gives the diagnosis of PTH cross striations. Beautiful cross striations. We did not do even the eyes in this case. Even the special stains gives a clue.
Yes, very nice.
Very nice cross striation, yes. So, Vimentin positive, Desmin positive, Myogenin positive, CK negative, S100 negative, SMA negative. So, pleomorphic rhabdomyosarcoma. So, I have told you already that the tongue is a structure where we find muscles, we can find nerve, we can find blood vessels, and tumors may originate from three sides, both of all these areas. Now, this tumor is very important and very interesting. Is that it has a stretched. Here we find tongue papillae is stretched and they are quite big. But here we find that the tongue is absolutely, there is no tongue papillae. The mucosa is stretched. It is absolutely whitish in color, huge tumor. So this part of the tongue is involved and has gone from the dorsum up to the ventral aspect. Now what are these cells? There are two types of cells. There are some spindle cells and there are some glandular cells. Spindle cells and glandular cells mixed.
Audience?
These cells are arranged singly, not in compact pattern. These are arranged in compact pattern. Means these are the epithelial cells. These are the stromal, these are spindle cells. Sarcomatoid carcinoma, synovial sarcoma.
Two differential diagnoses, yes.
Because of the
pattern was noted, number of people have noted the biphasic pattern. Synovial sarcoma diagnosis has been given. salivary
because
gland tumor has also been considered by some.
because I'm dealing with sarcoma. That is why it was given as biphasic synovial sarcoma.
Yes, sir.
We always back calculate na, sometimes
Yes,
because we are dealing with the oral sarcomas,
yes.
intraoral. So it will be biphasic synovial sarcoma, isn't it?
That's what audience seem to think.
I was also thinking they are not wrong. We are also thinking of biphasic synovial.
Salivary gland tumor is also being considered by Dr. Ashok Prasad.
What type of salivary gland tumor?
Mm, Dr. Ashok, you want to say which type of salivary gland tumor, or others who are saying salivary gland tumor? Dr. Deshawala, Dr. Gangadhara, you want to specify which type? Dr. Neelam Srimani wants PTAS10. Dr. Smita Javeri wants Desmin.
We will show everything. So we see these are the glands. Similarly, that we found these are the stromal cells. As we found on FNACC, beautiful FNAC where we find glands and the stromal cells. Here we also find glands and the stromal cells. Both are malignant. There is no doubt.
Yes, sir.
Both are malignant. And this is the high power of the glandular element. It's a beautiful gland. These are epithelial cells. Plenty of mitotic figures, pleomorphism is there. Rounded cells or rounded to oval cells, abundant cytoplasm.
Carcinosarcoma is one diagnosis being given.
Yes, it is quite good. Carcinosarcoma.
Angiosarcoma, one more.
Why angiosarcoma?
I don't see any RBCs or any clue that there is arising from blood
There,
vessels, but
there are two types of cells, glandular cells and the spindle cells, means the mesenchymal and epithelial elements. These are the epithelial elements, these are the mesenchymal elements.
yes, sir.
They are clear cut.
Yes, sir.
Now both are positive. Cytokeratin is positive, hymentin is positive. These are the spindle cell component, this is the epithelial component. Even the spindle cell component is focally positive also. So these are the areas where we create lot of confusion. What to do? Sarcomatoid carcinoma of tongue. Why? Why sarcomatoid carcinoma, not biphasic synovial sarcoma? That we have to take into consideration. We'll move and see why it is not.
Yes, sir.
Sarcomatoid carcinoma common sites are larynx, tongue, gingiva, nasal cavity, pharynx, esophagus. According to WHO, a biphasic tumor composed of malignant epithelial and spindle cell component with mesenchymal appearance but of epithelial origin. Carcinoma cells have potential to express mesenchymal phenotype at light, EM, and IC. Sarcomatoid component resembles sarcoma like fibrosarcoma, malignant rhabdomyosarcoma, even osteosarcoma, chondrosarcomatous area can be seen. Epstein-Barr virus carcinogenesis. That is the differential diagnosis of sarcomatoid carcinoma versus biphasic synovial sarcoma, biphasic malignant mesothelioma. So this is the important. This is taken from the literature. Synovial sarcoma from Science Direct. I have got it for teaching purposes. We find malignant mesothelioma, biphasic and biphasic synovial sarcoma. How to distinguish? First is that in cases of sarcomatoid carcinoma, there are lots of nuclear atypism, nuclear pleomorphism is more common in sarcomatoid carcinoma. But in synovial sarcoma, these spindle biphasic, they are not so much pleomorphic. That is very characteristic. Even in case of malignant mesothelioma, there are occurs in sarcomatoid component, there definitely occurs some pleomorphism, but it's absent. Then comes the keratin. Keratin, it does not give a clue because it's positive both for sarcomatoid carcinoma and sarcomatoid mesothelioma. EMA gives a clue, possibly whether we are dealing with a biphasic synovial sarcoma. We can do calratin and WT1 for epithelioid component of mesothelioma. Loss of BP1. TLE may be positive also in synovial, but TME there may overlap because TLE is positive in synovial sarcoma as well as mesothelioma. So we cannot give a diagnosis on this. So best is we have to do the molecular studies. So here it lies the importance of molecular studies, because these are the areas where we find totally gray zone of the soft tissue tumors, where cytokeratin positive, vimentin positive, but we have to see whether there is nuclear pleomorphism. This pleomorphism is not so much seen in synovial sarcoma, but it may be seen in malignant mesothelioma biphasic. But malignant mesothelioma, calcitonin and WT1 will give a clue, and loss of BP1. TLE will give a clue of synovial sarcoma, but it's not a marker because it also comes in mesothelioma and others, spindle cell like malignant. But in biphasic, it has no role. It can be differentiated from TLE, can be differentiated in monophasic synovial sarcoma, provided we exclude the malignant peripheral nerve sheath tumor, which are also cause positivity with TLE1. So in difficult cases, cytogenetics and molecular studies have to be done. SYT, gene fusion.
Dr. Javeri wants to know whether CD99 and EMA was done.
The CD99 EMA was done in this case. EMA was done, but EMA was also positive.
Okay.
In this.
Okay. Thank you.
But the problem lies in the both of them are positive for the epithelial marker, that is the cytokeratins and vimentin. EME is definitely present in sarcomatoid carcinoma, but with the exception of sarcomatoid renal cell carcinoma, but is not of renal cell origin. EME is, that is why I give a red mark. EME is important. We can see that the pleomorphism is important. We can see TLE may be important in cases of this, but maybe overlap with mesothelioma. Calcitonin and WT1 is positive for epithelial mesothelioma, which can distinguish these tumors. So calcitonin and WT1 can be done, but best is if we do the molecular, that is SYT gene fusion, and that is the hallmark.
Sir, Dr. Saurabh Gaur wants to know what is the role of vimentin in carcinosarcoma?
In vimentin carcinosarcoma.
What is the role of vimentin in carcinosarcoma?
In carcinosarcoma, vimentin becomes positive in the mesenchymal component, which is a part of epithelial component. This epithelial component transduces the mesenchymal component, and it is a part of epithelial which has undergone into a mesenchymal. And how it has undergone, I will show in the next slide. So that is why vimentin becomes positive. Also, it becomes positive also in synovial sarcoma. Sarcomatoid, but the pleomorphism of synovial sarcoma is not present in case of sarcomatoid carcinoma. There is plenty of pleomorphism that already has been highlighted. You can see there are plenty of pleomorphism in the spindle cells and the epithelial elements. But this type of pleomorphism is not seen in biphasic synovial sarcoma. Now, the theories, if we can explain, that will give a diagnosis why it becomes positive with vimentin. We can see that there are separate stem cells may come. Separate means two stem cells, one is going into a carcinoma, another is going into a sarcoma. So two separate stem cells giving rise to biphasic tumor. And carcinosarcoma, we can distinguish by a sharp line of demarcation. If there is well-mixed epithelial and mesenchymal elements, carcinosarcoma is ruled out. Carcinosarcoma, there is sharp demarcation. The epithelial component and the sarcomatous components will be differentiated by a sharp line of demarcation. Now, number two, the spindle cells, they causes atypical cellular proliferation of the stroma. Number five, the cells may be from monoclonal in origin. Monoclonal means one cell line, and this cell line undergoes dedifferentiated transformation to spindle cells occur. So monoclonal theory is now accepted. Separate stem cell theory is also been previous. Then atypical reactive proliferation of the stroma is also a part, but the monoclonal theory is now accepted, means one cell line is going and which dedifferentiated or transformed to spindle cells. This is monoclonal. That gives a clue why it becomes both positive for vimentin and epithelial and cytokeratin. This monoclonal means one cell line going into this, and here two cell lines, one is sarcoma, another is carcinoma, which are mixed. Another is the epithelial element, which creates a reactive to the stromal element. That is reactive proliferation, separate cell line, monoclonal origin. And these monoclonal origins dedifferentiate transformation to spindle cell occurs. Now, molecular pathology and genetics is very cumbersome in sarcomatoid carcinoma. Sarcomatoid carcinoma shows features of epithelial mesenchymal transition. This is epithelial mesenchymal transition, means epithelial component going into the mesenchymal component. This is by upregulation of the repressor and downregulation of microRNA. So by these theories, this sarcomatoid carcinoma creates lots of problems. And for this, we have to go into the morphology very well, because morphology gives a clue how the two types epithelial mesenchymal elements are mixed, how the cells are look like, whether they are pleomorphism, mitotic figures, and pleomorph is there, whether there is absent or whether it's present, necrosis, whether they are present or absent. So by this way, we can see the morphology thoroughly. Then we can take the help of IHC. And if IHC becomes a overlapping feature, then we have to go to the molecular. So this is a part where we have to deal with. So with this, I wish to thank you very much. And this is endless thing. And this is Kedarnath. This Kedarnath is also in the midnight. See the moonlit night of Kedarnath.
Oh my God, what a beautiful picture, sir.
A beautiful picture. I myself went there in Kedarnath. This is the moonlit night, and see, this is the dark. Absolutely, this area is little bit of moonlight is coming. These are the military areas over here, and military tents and houses, and this is Kedarnath. Thank you very much.
So thank you so much, sir, for this wonderful journey into the spectacular world of soft tissue tumors, and that too in a location of oral cavity. We are sorry that in the initial time there was some disturbance in audio and video, but later on things settled down, and I think the disturbance is more than compensated by Dr. Asitava's wonderful oration, showing lots of clinical pictures, cytology, histology, and brown revolution of immunohistochemistry. Wonderful lectures, enjoyed thoroughly, and audience also has enjoyed thoroughly. They have participated very actively, and some of them have given brilliant answers, and I think they are our future speakers. So Dr. Ashok Prasad is saying, excellent sir, thank you. Satyadev Rana is saying, sir, how do you perform FNA of intraoral lesions? Do you use any sprays and
Yes, usually spray is given.
okay.
Spray is
And
given. Yeah, we have to tell the patient that it's not painful. It's because I have already told you that the needles should be in situ. We should not take out the needle and puncture different types.
okay, sir. Okay.
The needle should be there. The patient should cooperate. Someone should be given vocal anesthesia. What is vocal anesthesia? Means you should tell the patient the story going on, patient diversion of mind.
Vocal anesthesia is a very nice term, sir.
Vocal anesthesia. This is very important in case of intraoral FNAC. You go on telling someone, your assistant will go on telling a story, and the patient will listen to it, and then you put just a needle, suck it, again put the needle, syringe attached with the needle and suck it. Do not, and we make 2 to 3 FNACs, like not much, and the rest is good for cell block. And we
Sir,
have to take precaution that we have to puncture the non-vascular area. That we have to important.
sir, did you ever have a problem of like bleeding too much, because number of them were very vascular malignancies? So did you ever have that problem that it was bleeding and like
Yes, there was some problem, no doubt, of the bleeding. But bleeding was there, but that was from initial part when we are performing FNAC, from the initial part. But when as the imaging has come up, I started FNAC from when there was no image, only ultrasound. Ultrasound doesn't play much role in intraoral. Intraoral we have to do CT, because the intraoral ultrasound doesn't play a role. That time it was bleeding was problem, but when CT came out, we can see which are the blood vessels and which area has to be punctured. So with the help of imaging, it has come out very nicely.
sir, you can stop your screen sharing so that both of us are seen. And a lot of people are thanking you. Dr. Professor Mulazim Hussain Bukhari from Pakistan is saying, thank you very much, Professor Asitava. Dr. Archana Deshpande is saying, wonderful talk. Dr. Ankita Jetani says, excellent
Dr.
presentation.
Deshpande is from Nagpur.
Okay. She is saying,
I went there. She is a very good teacher. You
yeah.
can take an webinar with him, with her.
Yes, sir. I will contact her. Dr. Archana Deshpande, please give me your mail or something in the comment section of this YouTube. I will contact you. Dr. Ankita Jetani is saying excellent presentation. Dr. Janu Devi, Naresh Gurbani. Naresh Gurbani wants you to be back again and again. Nilesh Kapadia is also requesting you to give such case-based seminars again and again. Dr. Deepak Patel, uh, MJ Musica, Afrin Nadaf, Neelam Srimani, uh, Smita Javeri, Dr. Vishram Kulkarni, Dr. Rakesh Vaidya, then Dr. Deepak Kanapur, Asaduzman Asad, Ashok Prasad, Satyadev Rana. All of these people have thanked you. And I guess all of us have thoroughly enjoyed this Sunday evening. And I guess as people are.
But Dr. Sochin, I miss the crowd, the faces.
Sir, this is the best that we can do in the COVID times. I know.
I, I
But
usually go to conference to see the faces of from the dais. The dais is the best place where you see all friends sitting, they are enjoying with you, just like a gossip going on. No? There is no
yes.
question, only thing that we share. That is
Sir,
the
this is the best that can do in the COVID times. I look at it in a positive way. Conference happens once or twice a year, and here we are going to meet every month.
no,
So,
Dr. Sachin, I go to 8-10 places each year.
okay, oh my God.
I Kashmir. I went thrice by Seri Kashmir Institute of Medical Sciences. They invited
Okay,
me thrice over there.
okay, great, great, sir.
So my traveling is the best. My first aim. Then to give the lecture.
Okay, I guess you'll have to wait for like 1 year, and then I think we can all resume our conferences. And till
But
that time,
but you are doing a lot.
sir,
Everyone should be grateful. You are doing a lot. This by starting this, at least we can share our things with the friends. That is a very important.
sir, as they say, necessity is the mother of invention. And when COVID derailed all our conferences this year, there was only one way, and that was webinars. And I guess technology is ripe at the present time, because of which we were able to interact so positively. And I
Yes.
guess
Yes.
we will continue to do so in the future. And Professor Mulazim is saying, dear Professor Asitava, your 30 years collections are wonderful. Dr. Nishi is saying thank you. So many people have thanked you, and I guess all of us want you to back every month with number of topics that we are discussing. Lymph node is one problematic area for all the general pathologists. And then there are, I think,
See, all are very learned persons.
yes, sir,
They
but
are
still,
all, they are really very learned. We share our knowledge in the slide seminar discussion. They are very knowledgeable. Very
yes.
knowledgeable. I feel very happy that they have spent so much time with us. And you are the person who is the driver of this whole thing.
So I feel blessed that I am able to like sort of interact with people like you and so many learned audiences. They know so much more. I guess it's
Yes,
a learning
they
phase,
are
and
excellent.
as the medical council or national medical council as it is called these days, they want medical graduates to be lifelong learners, and that's what we are doing, I guess, and that's a very heartening
Yeah,
thought.
you are doing a lot. You are doing a lot. I'm really grateful. What you are doing is sacrificing so much time. Also in Sunday evening, you are spending with us. That is a great part of it. And Mulazim is you can take him in the lecture. He is excellent. He
Sir, okay, sir. I will get his email from you, and next time we will ask Dr. Mulazim to give one webinar on topic of his choice. I will interact with him, so definitely. Hmm? So I think with this, a beautiful session is coming to end. And I thank Professor Asitava for his wonderful oration. Enthusiastic participation by audiences was one thing which sort of lit up the evening. And I hope we have more interactive way to sort of reach out to each other and learn from each other. Audiences, thank you so much. And please give feedback regarding how we can make this better, and whether this timing is comfortable or usual 4 o'clock in the afternoon tea time is better. You tell me, and we will continue accordingly.
Yes,
I
yes,
think
that is the best time, Dr. Sochin. You ask the audience when they are best suited. I have no problem.
yes, sir. Yes.
When the
So
audience will be available.
yes, sir. Yes. So
I
I
thought
think
Sunday evening because they have no laboratories all closed, they are taking evening stroll. But you have a pressure, you have to come to the hospital, leaving
no
your
issue,
home.
sir. I can do that every 15 days or every month. It's not a big deal. I'll find out a way.
You are very busy from morning till night. from morning 8 o'clock till night 10 o'clock you are busy, and Sunday you take rest, and that day I go to hospital. That is not good, I think.
It's always a pleasure, but we'll try to find out a way. So I think with this, it's time for all of us to say goodbye to each other. Next time, I think there are lots of webinars related to pathology. So next time we are having a webinar on financial awareness for doctors. I think that is one topic that is, I think, very important for all of us, because ultimately we need to put something on the dinner table, and
Yes.
not only from the pathology, but I think, as they say, make the money work for you. And next time we have Dr. I think Aniruddha Gopan Palikar, who is a gastroenterologist and good friend of mine. He is going to give a talk on financial awareness for doctors, so that should be an interesting session. So I
Yes,
think,
we have to take care of two things. One is our brain, and that is given by pathology, and one is our stomach, that is given by food. So both, otherwise, how can you feed the brain without food?
yes sir, very true, very true. I think with this, it's good night, and take very good care.
My regards to all. Please pay regards to all who are present. That is
Yes sir,
my
they are
thing.
hearing you, they are loving you. Hmm?
Very good, close friends of mine. All are very close friends of mine. I
Okay,
miss them so much, but in your platform, they all come and they join. That is my pleasure. What
okay,
more can I tell? Thank you
okay.
so much, Sachin. Thank you very much.
Yes, sir. Thank you, sir. Good night, everybody. See you again after some time. Bye bye.
Okay. Bye bye.